Our topic for this session today is why is it important to routinely assess risk in pulmonary arterial hypertension patients? So we have learned a great deal about risk assessment over the years, and in particular, there were 3 registries that were published in 2017 that shed additional light on the topic of risk assessment in pulmonary arterial hypertension. The Swedish Pulmonary Arterial Hypertension Register and the Compara Register used very similar methods, and let's talk about those two first. The Swedish is obviously a Swedish registry. Compara is a European registry, primarily German. And what both of these registries did was really look at the risk determinants in the ERS-ESC guidelines as a method by which to risk assess patients. So the Swedish registry took incident patients diagnosed from January 1st to March 1st, all types of pulmonary arterial hypertension, and they categorized them as low, intermediate, or high risk based on the cutoffs for functional class hall walk, biomarkers, right atrial area, mean right atrial pressure, pericardial effusion, cardiac index, and SpO2 by the ERS-ESC guidelines. Basically, if the patient had a variable in the low risk category, they gave it a 1, intermediate risk, they gave it a 2, high risk, they gave it a 3. They then added that up and divided by the number of variables that were measured and rounded to the nearest integer. So if the final score was less than 1.5, that patient was considered low risk. 1.5 to less than 2.5, that patient was considered intermediate risk, and greater than 2.5, that patient was considered high risk. The Compara study did something very similar, but they narrowed it to 6 criteria, primarily because that was what was included in the database: functional class, 6-minute hall walk, biomarkers, right atrial pressure, cardiac index, and SpO2. They again looked at treatment-naive incident patients diagnosed between January 1st, 2009 and December 1st, 2016. Again, all types of group 1 pulmonary arterial hypertension, and they categorized patients as low, intermediate, or high risk using the same methodology as the Swedish. And then the French registry did things a little bit different. They determined survival according to the number of low-risk criteria achieved during their first year of treatment. And these were incident patients that were enrolled in the French registry between January 1st, 2006 and March 30th, 2006. They limited their population to idiopathic, heritable, and PAH associated with drugs and toxins. So they did not include the CTDs, the portals, the HIVs, and the like. And they defined 4 low-risk criteria, and that's how they measured the risk. And the low-risk criteria were being functional class 1 or 2, having a 6-minute hall walk of greater than 440, having a right atrial pressure of less than 8, and having a cardiac index of greater than 2.5. So those are 4 criteria that were used during the ESC-ERS guidelines table, but they limited it to just those 4. And they didn't consider intermediate or high. They basically just said, have you met this? Are you low risk? And counted how many of the low risk criteria they've met. So here is the data regarding the risk assessment at baseline. At the time the patient's diagnosed, what their score was and what their prognosis is based on the risk category that they fall into. And the findings are all very consistent. If a patient is in low risk in Swedish and Compara on the right and the left, you can see that the prognosis is very good, so the score of less than 1.5. Intermediate is in the middle, and the patients who present with a high risk, that score of greater than 2.5, have a pretty poor survival. In the middle, in the French registry, you can see by the number of low-risk criteria that are met, the more that they meet, the better the survival is. So that's at baseline, but we have so many therapies for patients these days. We can change their risk, and this next slide demonstrates the risk assessment at follow-up. And you can see how the curves separate even farther. If a patient is at low risk, no matter where they started, if they are at low risk at follow-up, they do much better than if they're at high risk. If we're treating them and they're not responding to therapy and they still have high risk variables, then their prognosis is particularly poor. And you can see even in the French registry, those curves continue to separate as well. And this slide really highlights the importance of achieving the low risk status at follow-up. And let's use the Swedish because it's a little more simple than the Compara. There's so many lines there. But in the Swedish registry, you can see if a patient was low risk at the time of diagnosis, as evidenced by the green line, and stay low risk, their 5-year survival is good. But I think what's really important is the blue line there, the light blue line. Those are the patients that were at intermediate or high risk and with therapy improved to low risk. Look at that. Their survival is as good as the patients who were diagnosed in a more low risk group. And so when patients ask me what's going to happen when I first meet them, what's my survival going to be, or what is the outcome, I always tell them it's too soon to tell. Response predicts response. If they respond to therapy, even if they're very sick when we meet them, they're going to do well. So this very nicely demonstrates that, and it's consistent amongst all the groups. And then you can also see that the patients who are at intermediate or high and stay stable there, they're not responding to therapy. Their outcome is particularly poor. And of course, it's very bad for patients, the red line, who worsen to intermediate or high risk. So this slide really highlights the importance of achieving that low risk status. And you can see in the French registry too, at follow-up, the more low risk variables you have, the better. Now, these registries are all very important. I think the data is very consistent in terms of getting to that low risk status, but I want to highlight some of the differences between them. You can see at the start, Compara is the largest registry and the Swedish is the smallest, but I think it's really also important to look at the follow-up. The French registry really had perfect follow-up, and you can see there's significant dropout in both the Swedish and the Compara. So there's a lot of missing data there. The Swedish and Compara registries included the associated PAH, and the French registry did not. It was just the heritable, idiopathic, and anorexogen induced. We reviewed already what they defined as low risk, less than 1.5 when you did the math for Swedish and Compara, and 3 or 4 of the 4 low-risk criteria for the French. The next line goes through the 1-year mortality by risk group at baseline, and you can see that looking specifically at Swedish and Compara, what the ERS-ESC guidelines guessed or estimated for the survival or mortality was really spot on based on this data. So the low-risk group, they had estimated an ESC ERS of less than 5% at 1 year, and what was the reality in the Swedish and Compara was 1 to 3%. In the intermediate risk, they estimated 5 to 10%, spot on, 7 to 9.9%, and in the high-risk group, it was greater than 10%, and you can see it's 20 to 25% in these different populations. It's very unfortunate we're seeing so few low-risk patients at baseline. We're still getting patients who have quite advanced symptoms at the time of diagnosis. Only 12 to 23% of the patients had low risk factors at baseline. But what's even more concerning is the number of patients we get to low risk at follow-up. We're really not getting as many people to low risk at follow-up as we like. Now, remember, these are historical registries that some of which started more than a decade ago, and we didn't have as much therapy then. And I'd like to think that we can do better now. We can get more of our patients into the low risk status at the time of follow-up. You see the French got the most patients to low risk at the time of follow-up, 41%. They're also the group that used the most initial combination therapy. And so I think this adds credence to the concept that we need to be more aggressive with our therapy for patients. So that was a summary of some of the publications on risk assessment, particularly some that came out of European registries in 2017. I think very consistent data, very compelling data that tells us not only that we should be assessing risk frequently, but we should also be doing everything we can to get the patient into a low risk status. Because even if they start out sick, even if they start out in a high risk status, if we can treat them aggressively and get them to low risk status, their long-term outcome is going to be better. So thank you for joining me for this session.